we have, as I think the rest of the world knows all too well, been dealing with some incredible divisions in thought and policy, and with an administration that seems reluctant to acknowledge scientific facts. And so maybe partly because of that climate, I wanted to explore something that's puzzled me as a clinician and a researcher ever since we first made our initial observations about the relationship between orthostatic intolerance and ME/CFS now a little over 20 years ago. And that is that there's been a consistent willingness of a proportion of the academic community that has discounted the accumulated evidence about orthostatic intolerance. And it has ignored the practical value that recognizing and treating this condition has for the overall function in people with ME/CFS. So today, after framing these dissonant opinions about the orthostatic data, I want to move on to look at our initial observations of the overlap from the early 1990s, review the evidence on orthostatic intolerance that was produced by the Institute of Medicine review that you heard a bit about earlier today, try and understand why we have so much heterogeneity, especially in the adult studies of this problem, and then I'll end with some personal reflections, 5 lessons that I think relate to these points. First, some definitions for those who don't spend their time in this field. What we mean by orthostatic intolerance is a group of clinical conditions in which symptoms worsen with quiet upright posture and are ameliorated, although not necessarily abolished, by recumbency. The symptoms one gets if one is not getting enough blood flow from gravitational pooling back up to the heart and brain are shown on this slide. The ones on the left-hand side of this slide are attributed by most autonomic experts to inadequate cerebral blood flow. And we'll be hearing more about that in the talk after mine. But things like lightheadedness, diminished concentration, and headache make sense. Every study of orthostatic intolerance conditions also reports high prevalences for fatigue and exercise intolerance. So that column has a huge amount of overlap with ME/CFS. The symptoms on the right in the autonomic literature are usually attributed to high catecholamine rates or levels that are the physiologic consequence of trying to respond to an excessive amount of blood that's pooled in the limbs. These are the 2 common forms of orthostatic intolerance that we see. On the left is POTS, or postural tachycardia syndrome, which we define as within the first 10 minutes of head up tilt or standing, a 30-beat increase in heart rate between supine and that 10-minute period, and that's in adults. We've learned that it needs to be a 40-beat increase for children 19 or under, and it cannot occur, POTS can't be diagnosed if you have orthostatic hypotension, which is a drop of 20 systolic or 10 diastolic in the first 3 minutes. And usually, and this requires persistent orthostatic symptoms. You can't just have excessive tachycardia with no chronic symptoms. The heart rate is often above 120. On the right is neurally mediated hypertension, which many of us learned about as vasovagal syncope. We prefer the term neurally mediated hypotension not because it's so cumbersome, but because many of the patients have not been syncopal in day-to-day life, and so the physiology is the same, but they've never had, some of them have never had fainting. And that graph is the tilt test on a medical student at Johns Hopkins who failed her first year because of fatigue and cognitive problems. And you can see that her heart rate went up about 9 beats. She got immediately lightheaded and pale, and at the 5-minute point, there was a profound drop in blood pressure to below 50 millimeters of mercury with a drop in heart rate, which is classic for the vasovagal syncope pattern. And you can perhaps read that on the way down, she got a couple of tonic-clonic movements as well, reflecting the reduction in cerebral blood flow at that point. This is maybe not showing up all that well, but this was the cover graphic from the Institute of Medicine report. They had convened a committee in 2014 of content and methods experts to look at the diagnostic criteria for ME/CFS, and the committee reviewed a little over 9,000 papers. The substantive part of the committee's work was the evidence review. We recognize that the name we generated was a bit of a clunker, but the evidence review is really what we'd spent the majority of our time on. And the summary statement on orthostatic intolerance reads this way. Sufficient evidence indicates a high prevalence of orthostatic intolerance in ME/CFS as measured by objective heart rate and blood pressure abnormalities during standing or head-up tilt, or by patient-reported exacerbation of orthostatic symptoms with standing in day-to-day life. These findings indicate that orthostatic intolerance is a common and clinically important finding in ME/CFS, and the committee viewed that orthostatic intolerance was a core symptom of the illness. A little while later, maybe within a month of publication of the report in February, there were a couple of comments by a well-known British investigator who gave the opposing view, which was orthostatic intolerance is questionable when good epidemiologic studies find that objective evidence of OI occurs in a relatively small minority of patients. He went on in one of the online publications to state, some would question whether orthostatic intolerance is a key feature. So here we've done this huge systematic review, and this was one of the responses. So what are the implications of that view? Well, if you think orthostatic intolerance is uncommon and unimportant, if you believe it's entirely an epiphenomenon of deconditioning and inactivity, then you could continue to advocate a largely behavioral approach to the illness. And that's essentially what you get in the NICE guidelines, with no mention of the utility of assessing for or treating comorbid orthostatic intolerance, instead emphasizing GET and CBT. On the other hand, our physicians who, from the global community who treat this illness, who feel that treating orthostatic intolerance is the most treatable component of ME/CFS, and it's an important part of managing the symptoms. So those are the poles of the debate. And the two camps have much less disagreement, in fact, when we are talking about treating headaches or treating insomnia or treating pain. But when it comes to orthostatic intolerance, what I've been puzzled by is the guidelines of treatment from the people who focus primarily on CBT are really quite silent on the management of orthostatic intolerance. Well, let's look at some of the evidence starting back in the 1990s when we looked at this problem. In a pediatric diagnostic clinic, we were looking at patients who came in with undifferentiated problems. We saw a number who had spells of fainting, and then also a number with chronic fatigue syndrome. And we noticed that the situations that provoked symptoms for both groups were very similar. Standing in line, taking a hot shower, going shopping. I was able to recruit some cardiologist colleagues. One was shown here on the upper right. One was Isam Bohalega, who's a pediatric cardiology fellow from Saudi Arabia. The other person in the picture is Hugh Hopkins, who's the head of our EP lab at Hopkins. And we asked the question, is neurally heat-mediated hypotension an unrecognized cause of chronic fatigue? So we had 7 consecutive non-syncopal adolescents who had chronic fatigue, 4 of whom met the existing criteria for CFS. And what was interesting was that all 7 had a hypotensive response on the tilt table. What upped the ante a bit more was that 4 of the 7 had very substantial improvements in their fatigue levels and their function when we treated them with medications that were designed for the management of people with neurally mediated hypotension. We went on from there to ask whether if we took a group entirely consisting of people with well-characterized CFS, not mixed in with those who had chronic fatigue syndrome, what would happen? And in that study, published in JAMA in 1995, we did a 3-stage tilt table test, which tilted people upright to 70 degrees for 45 minutes. That was stage 1. If they tolerated that, the table was put down. We started isoproterenol to mimic the effects of day-to-day stresses and to drive their heart rate up by 20%, and we brought them up for 15 minutes. The third phase, after another a few minutes supine was high-dose isoproterenol for 10 minutes, 4 micrograms per minute. We've since abandoned that third stage because if you give people enough isoproterenol, you can make anybody faint. But that was not knowledge that was available at the time. What we saw in this study was that the features compatible with orthostatic intolerance in this group that came in with CFS included lightheadedness in 96% when you asked specifically about that, diaphoresis in 83%, and 43% had been syncopal. The conditions that exacerbated their fatigue included physical exertion, which we would expect by definition, but also over 70% had symptoms worsened by a hot shower, by prolonged standing, and by warm environments. This was the three stages of the tilt test. Note that in stage 1, without any medication to stimulate syncope, 16 of the 23 CFS patients and none of the 14 controls became hypotensive. As the isoproterenol dose went higher, we started causing hypotension in a couple of the healthy patients. But the odds ratio, I think Don was talking about the odds ratios for his immunology studies. This was an odds ratio of 55 for an abnormal tilt if you had CFS. Even if you take the lower part of that 95% confidence interval, we were at 5.4%. What was even more important than the actual hemodynamic numbers was that all of the CFS patients had a bad day on the tilt test. We were able to exacerbate their symptoms, and often those symptoms remained worse for several days afterwards. They got worse fatigue, lightheadedness, warmth, nausea, and diaphoresis. We then went on to an open treatment trial. This whole JAMA paper was really a pilot study aimed at generating data to help with the design of a randomized trial of Florinef. And 9 of the 19 who agreed to treatment had responses that were quite substantial. We used as our measurement tool the wellness score, which had been used by Steve Strauss in a couple of the NIH trials. This is anchored at 0 for dying and 100 for feeling as good as you could imagine feeling. And it correlates very nicely with things like the SF-36. It's a single unidimensional measure. We asked them how they've been feeling over the previous 2 weeks, and the mean score went from 36 at baseline up to 69 after 4 months of treatment. So that was really pretty substantial and very similar to what we see to this day. Our Florinef trial provides another window on how common orthostatic intolerance might be. In that trial, we used a 2-stage tilt. 62% of these patients that were screened had neurally mediated hypotension. 4% had POTS alone, and a proportion of about 24%, I believe it was, had POTS before their hypotension developed. Since then, it's emerged in most centers that POTS is the more common form of NMH. We're not sure why the shift. We think it might be to changes in the sodium intake of people with the illness. Even if you account for some people choosing to enroll in this trial because they expected treatment, this is still a very high rate. And I would emphasize that among the normals in this study, every one of them had an exacerbation of CFS symptoms, even if they didn't have hemodynamic changes during the tilt test itself. So if we move then to the Institute of Medicine review, the pediatric data are quite consistent, and I'll just summarize those on the next slide. Every single pediatric study that has looked at OI and had controls has shown a higher rate of orthostatic intolerance in pediatric ME/CFS patients. I'll point out a couple of findings. Julian Stewart, who's been a prolific contributor on orthostatic intolerance, found that overall 96% of his patients had orthostatic intolerance. Tanaka from Japan did a very short 7-minute period of standing, and they were using near-infrared spectroscopy and showed a delayed recovery of cerebral oxygenation in 3/4 of their CFS patients versus 10% of the controls. I saw on the list that there's some people here from Oslo, and Vigard Willer gets a great deal of credit for a very inventive change in the tilt test protocol he used. he found that when they were doing a couple of patients in the healthy control arm, that tilting them to 70 degrees, a couple of them fainted. So he said, let's drop the tilt angle to 20%, which would be most of us taking a lie down on the sofa on the weekend and not a physiologic stress. So that removed the number of patients in the control group who were, or people in the control group who were likely to get orthostatic changes. 20% or 20-degree tilt was enough for people with ME/CFS to develop hemodynamic changes. So his maneuver accentuated the differences between the groups. And they showed a higher heart rate and diastolic pressure as well as higher sympathetic tone in the ME/CFS group. The adult data are less consistent, and I'm going to show you a slide that is deliberately unreadable except for the top and bottom. The prevalence of orthostatic intolerance in the 14 controlled studies of prolonged, meaning more than 10 minutes of orthostatic testing, the majority of those studies show a higher prevalence in the people with ME/CFS. If you summarize these, and I understand that this compilation of observational studies is not always the best in meta-analysis arenas, but 42% of those with ME/CFS had orthostatic intolerance in the first 45 minutes of upright tilt, and only 15% of the controls. Now there's a ton of variability. Some people found 0% abnormalities in the ME/CFS, and others found up to 79% in the first 45 minutes. So what might account for the heterogeneity in these studies? And I think as we think about this, I'm reminded of a quote from David Spodek, one of my favorite quotes in the clinical epidemiology literature, and that is that we must view published material critically, if not biblically, for too often the conclusions giveth, but the materials and methods taketh away. So let's look at one of the so-called negative studies that was in that list I showed you one slide before. This was from the CDC. It was their Wichita prevalence study. It was a population-based screen for people with ME/CFS. And they found 74 with CFS who were eligible for a head of tilt. They excluded 41 of those 73. A couple of the reasons were appropriate, right? If you had an age greater than 55, that was in many of the tilt studies. They didn't want to provoke coronary disease. If you're on medications that might affect the validity of the tilt, that's a reasonable exclusion. But remember the heart rate of 120, which we see in POTS. They excluded people with a heart rate of 120. So from the outset, they were excluding the people that they were trying to measure. It gets better. They then had 33 eligible people for tilt testing. 23 of them refused. I think the word had gotten around from our studies that you're going to feel pretty miserable afterwards. And they were left with 10 people to study. And from this, they found a prevalence of 3 out of 10, or 30%. And I would submit that any student who's taken an epidemiology course knows that this sample size wasn't representative of the population under study. They only got 14% of the original sample. Not only that, if you look at the 95% confidence intervals around the estimate of 30%, it could be as low as 2%, or it could be as high as 58%, which is a lot closer to where most of the rest of us have been finding these data to fall. I've got a couple of slides that I'm going to go through pretty quickly. These are on the the methodologic problems in tilt testing that could be contributing to some of the heterogeneity in the rest of the papers. One is the duration and severity of the illness. Another important one that isn't talked about much is the expectations for treatment. If you go to a study knowing that you're just going to be volunteering with no expectation of improvement, that might be different than if you go to a study where you expect to get treatment. People have talked about joint hypermobility and Ehlers-Danlos syndrome. We know that the rates of orthostatic intolerance in those groups are much, much higher than the average person in the population. So depending on the proportion one gets with Ehlers-Danlos syndrome in the study population, your results could be very different. Cardiologists vary on the duration of the pre-test fasting. 2 hours after a meal versus overnight, you're going to get very different results. The time of day can differ. Those tested in the morning are more likely to have orthostatic intolerance than in the afternoon. The tilt table duration. I've seen studies of just 3 minutes. Those will completely underestimate the proportions even with POTS, and they won't detect the patients who have neurally mediated hypertension. So there are a lot of methodologic factors that go into the heterogeneity. So with that as the methodologic background, let me mention 5 lessons that I've chosen because I also think they illustrate this gap in the practice that we've described earlier. The first is that orthostatic intolerance, if it's associated with ME/CFS, then you'd expect that patients who have orthostatic intolerance but don't quite meet the CFS criteria would have at least some of the same symptoms. It's not a black and white problem. There's a spectrum of symptoms. And so let me show you 2 slides that I think relate to this. This is a slide from the Vanderbilt Autonomic Group who looked at people with CFS and POTS and compared them to their non-CFS POTS patients, that is, people who met criteria for POTS but didn't meet the full criteria for CFS. And what you can see on the y-axis is the Fukuda criteria, and note that the patients who had both CFS and POTS had a higher, had a different prevalence rate of the CFS-related symptoms, but the POTS patients also had many of the same symptoms. They just didn't have 4 of the 8 required for the diagnosis of CFS. Another group that has done a lot to contribute to the work on orthostatic intolerance is Julian Newton's group in Newcastle, and they extended these findings with an elegant study that looked at the COMPASS questionnaire, which looks at lightheadedness, yes, but also a number of other orthostatic or other autonomic symptoms: bladder dysfunction, bowel dysfunction, and sweating. And the COMPASS scores were significantly different in the CFS patients versus the controls. And not only that, the COMPASS severity score correlated with the fatigue impact scale. Second lesson relates to the way we describe cognitive dysfunction in this illness. Many people in the orthostatic literature talk about cognitive dysfunction as a direct consequence of things like orthostatic hypotension. Whereas in the ME/CFS literature, we often think of it as having several possible triggers. We do, I think, do a very poor job of ascertaining whether cognitive symptoms are more likely to occur when people are upright. We just don't ask about that enough. But if orthostatic intolerance is important in the pathogenesis of ME/CFS symptoms, evidence ought to exist that upright stress, orthostatic stress, can aggravate cognitive symptoms. And I'll return to my friends Marvin Meadow and Julian Stewart, shown on the right. They published a very nice paper in 2012 showing that if you increase the orthostatic stress, you could impair neurocognitive functioning in CFS patients who also had POTS. And they used an NBAC test, which measures working memory and attention. And I think you can see that as the tilt angle was increased from 0 to 15 to 30, once they reached a tilt angle of 45 degrees, the CFS patients had more problems with reaction time and errors, and that got progressively worse as the angle of the tilt came up. When they looked at the complexity of the cognitive task, 0 back is the simplest, 4 back is the most difficult. Again, there was a progressive increase in the number of errors and problems with orthostatic stress combined with a cognitive stress. I want to now talk about activity in a couple of these lessons because we know that inactivity can aggravate orthostatic intolerance in ME/CFS and in those without ME/CFS. But I think it's really important to recognize that it's incorrect to view orthostatic intolerance as exclusively due to deconditioning, as is often the challenge that we get thrown at us. Here's a paper from some studies, or a slide from a study done in NASA volunteers trying to understand why people who went into outer space came back with orthostatic intolerance. And these were folks who were on complete bed rest for up to 220 days. I don't think that would get past an ethics committee these days. But the point is that within the first 2 to 3 weeks, up to 15% of plasma volume was lost. That's going to make you orthostatically intolerant. So we try to get people to avoid complete bed rest wherever possible. But there was one of the challenges to the notion that it's all deconditioning is the fact that we see athletes with this. I've taken care of a number of swimmers who are gold medalists who have POTS. They clearly are not deconditioned. H.L. Mencken, who's a Baltimore journalist in the early 1900s, wrote that for every complex solution or complex problem, there's a solution that is simple, neat, and wrong. And I think that's really how we need to look at the notion of deconditioning as an adequate explanation for orthostatic intolerance. And the person in the slide is Michelle Akers, who is really one of the best soccer players in the world. She was a FIFA player of the world at one point, was on the women's soccer team for the US when they won the Gold Cup, and had horrible ME/CFS, needed IVs in halftime and after the game. And so she was clearly not deconditioned, but she had these symptoms. We all agree, I think, that more normal tolerance of exercise is the goal of treatment in ME/CFS. What we've found is that effective management of the orthostatic intolerance often enables tolerance of graded increases in exercise. And so I want to show you a patient who illustrates that. This is a 22-year-old who got sick with a CMV-driven illness at 14. By the time I saw her a couple of years later, she had orthostatic intolerance, she had joint laxity, hypothyroidism that was now treated, she was euthyroid on treatment, Raynaud's phenomenon, she developed some mild depression 2 years into the illness, she had migraines, and had, for the PTs in the audience, neurodynamic dysfunction, limited range of motion on her physical therapy exam. She sort of pushed through, like we would hope all of our patients can, to complete high school and university on a full-time program, mainly on fumes and grit. We couldn't find anything to help her headaches, despite using most of the standard treatments. She got a little bit of benefit from increased salt and fluid and compression garments, but none of the standard medications worked for her. And the problem was that she had a resting inappropriate sinus tachycardia of 104 to 140 beats per minute, really a profound abnormality on somebody walking into the clinic. And when she tried to exercise, which she did regularly, within 2 to 3 minutes her heart rate would be up to about 180, and she would exacerbate her migraines for the next 2 days. So it made no sense for her to exercise. She wanted to, but she couldn't. So you guys had access to ivabradine a number of years before we did in the US, but once it became available for treating inappropriate sinus tachycardia, we started her on it. As we increased the dose gradually, she had a progressive decline in her resting heart rate. On 5 milligrams twice a day, she was down to a heart rate of 90. And when she exercised, she was now only going up to 155, which is higher than most of us would get, but this time without triggering her migraines. She loved it. She kept going, we pushed the dose up, and at 10 milligrams twice daily, she's got a resting heart rate of 72, goes up to 130s with 40 minutes on the elliptical, feels sharper, and has no headaches. And the p-value for this N of 1 study is shown on the next slide, where she sent me this picture. We made a weekend trip to Sedona, did 10 miles of hiking in a day with the last hike up to Devil's Bridge. And so it's important to address the orthostatic intolerance so they can exercise. And that's been our experience for 20 years. When we take them off a medication that has helped, they often get a resurfacing of their ME/CFS symptoms, even though they're not deconditioned at that time. And so my analogy, when I'm talking to the residents, is that when asthmatics are able to exercise without symptoms, we talk about them as being well managed. We certainly wouldn't ask an untreated moderate asthmatic to get themselves better by just starting an exercise program without supporting them with anti-inflammatories or bronchodilator treatments. And yet some of my colleagues are quite happy asking them to exercise their way out of their POTS without using medications. The last lesson is that this isn't a homogeneous problem. Orthostatic symptoms in ME/CFS can also be triggered by other things, and these include adverse neural tension or neural tension dysfunction, terms that are more familiar to the physiotherapists in the room. we had noticed that many of our patients sent to physios would call me the next day saying that they were excessively fatigued after the initial assessment before any treatment had started. If they stuck with it, they started to improve after a few sessions of treatment. So we brought 2 of the young boys in. These are college students, and we did a test where we raised their leg to 10 degrees for 2 minutes, measured heart rate and blood pressure, went to 20 for 2 minutes, did the same thing, all the way up to 60. They were doing no active work. And you can see that their symptoms really got provoked, including lightheadedness, which shouldn't have changed given that they were getting more blood flow back to the heart. We've followed that up with some other papers if people are interested, and this is these are the wellness scores we see recently, going from about 50 at study entry using multimodal therapy, including orthostatic intolerance management. They got up to 75. So I hope I've convinced you that the majority of adult and all pediatric studies show orthostatic intolerance is strongly associated with this illness, that upright posture consistently aggravates symptoms, often long before we see changes in heart rate and blood pressure, and that the open treatment of NMH and POTS is associated with treatment in improvement in fatigue and other symptoms. And I'd just like to thank the people who've supported our work over the years, including the Sunshine Natural Wellbeing Foundation, who have endowed a chair in chronic fatigue research, the number of summer students, and most of our studies are done with the benefit of private philanthropy. So I'll stop there.